Hi everyone, today we're going to be talking about elimination. Most of the medications that I'm going to be talking about today you're very familiar with. It's fortunate that we have these medications. It's unfortunate that we need to give them as often as we do, I would say, and I know you probably could concur with me that most of the patients that are assigned to us are taking at least one of these medications maybe once, maybe twice a day, very commonly in the hospital. And there's a lot of reasons for that. I'm going to talk about the most general to more specifics as I get into this. But I would say something that's glaring to me is the lack of mobility with our patients in the hospital now. When I started out in nursing, we did not need to see an order out of bed for every meals. And I'm starting to see that more in the hospital, out of bed for every meals. As nurses, we should not need to be told to get our patients, if they're able, out of bed for every meals. So the lack of mobility directly impacts our patients. And then we all know there's so many other factors. Maybe I'm predisposed because I have IBS. Maybe I have ulcerative colitis. Maybe I have a history of colon cancer. Maybe I'm taking other medications that affect my intestinal mobility. So we're going to kind of go through. You guys know how much I dislike big pharma, but I am grateful for some of these meds. What's neat about elimination meds as well is that a lot of them are natural, that you wouldn't know. You would have thought, oh, this is synthetic. It's made by, one of the big pharmaceutical companies. It's not. Some of these meds have been around for hundreds, if not thousands of years, that we're still using and are still pretty prevalent in the hospital setting and even, over the counter at the drugstores as well. So without further ado, let's get into it. So the first medication that we're going to talk about falls into the classification of antidiarrheals, and the prototype we're going to talk about is loperamide, also known as Imodium. We do give that in the hospital, not often for many reasons, but the indication is for non-specific diarrhea, chronic diarrhea, maybe from IBD or traveler's diarrhea. This is not something that we just readily give to our patients if they do have diarrhea, and this is where I wish I was in the classroom kind of teaching you guys, because I ask you lots of questions around this. But why wouldn't we just readily call the doc and get an order for Imodium? Because we have to rule out any other causes first, right? And what is the most common cause for diarrhea, especially frequent stools in the hospital, unfortunately due to antibiotic use, is C. diff, okay? So if we give our patients Imodium and they have C. diff kind of brewing and overpopulating, getting out of control in their intestine, we're not going to be able to control that, manage it. Oftentimes they have to have stools, especially if they have a stomach virus, have stools to kind of get over that sickness, get over that illness, and Imodium is just going to slow the progression of that. So the action, what does Imodium do? Directly affects the intestinal wall muscles through opioid receptors. The therapeutic effect, it slows intestinal motility. It prolongs transit time of intestinal contents by reducing fecal volume. Okay, so unfortunately with Imodium, it seems like, geez, it's a common medication. You can buy Imodium over the counter. ADRs, though, that we're looking at is potential, not common, but based on the dosing. And if I'm buying Imodium over the counter, then the dosing's up to me. And if I'm a lay person and not really educated in the dosages, or maybe I can't even read the directions on the back of an Imodium bottle because the fine print is a font of like 0.5, for goodness sake. So I might miss the ADRs of taking too much Imodium, but I might be at the end of my rope and I'm sick of having diarrhea. So what could happen? It has some cardiac implications. Well, first, we're not to give Imodium to children under 2. But, any individual 2 or older, especially into the adult age, there's been cases of torsades. I don't know if you guys have learned about torsades yet. I think you have, but torsades de pointes. It's a lethal cardiac arrhythmia, dysrhythmia, and it's called torsades de pointes. It's like ballet points in French, where on the telemetry strip it literally looks like, they would say, the French would say, the ballerina dancing on the tele strip. So torsades de pointes. And it's lethal. It's caused by some electrolyte disturbances So we've had cases of cardiac arrest, sudden death. So, I mean, the general rule of thumb with Imodium is if your symptoms don't improve in 48 hours, to consider another drug, let your provider know. But nursing implications for this, common side effects, we need to make our patients aware of the common side effects: dry mouth, dizziness, abdominal discomfort, constipation, of course. So a lot of these are going to have very similar implications, very similar common side effects. Do not administer with presence of bloody diarrhea. That kind of, I feel, goes without saying. Do not administer with a temp greater than 101. That kind of goes with, you have a virus probably brewing, so maybe you don't want to be taking Imodium. You want to seek some medical supervision under that circumstance. Encourage fluid intake. Anytime there is diarrhea present, we have the increased risk of throwing off your electrolytes, and then of course report diarrhea that's persisted for greater than 3 days. So that's all we're going to touch on as far as antidiarrheals go. We could, in this lecture and this content, we could go on and on and on, as evidenced by watching any commercials or going to a drugstore and seeing all that's available for elimination needs. But to focus on the antidiarrheal, I was going to say Lamodal, but that is another one. Imodium is about as far as we're going to go with that today. But let's talk about laxatives. That's probably the most common medication we give for elimination in the hospital. What types of laxatives are we going to talk about today? So we're going to talk about chemical stimulants, and those are medications that affect the nerves in the bowel. We're going to talk about bulk stimulants. That increases the bulk, stimulates peristalsis. That's the movement in the intestine, right? Talk about lubricants. That lubricates fecal material or changes, like cholase. It's technically classified as a lubricant, but it technically changes the surfactant in the intestinal wall, whatever. We'll get into that. And lubricants enhance passage, of course. And then GI stimulants. It stimulates the parasympathetic activity. I kind of like the mechanism on that. Okay, so why are we giving laxatives? Maybe the patient has painful elimination, maybe they have hemorrhoids, maybe they've had an episiotomy. If you haven't gone through L&D yet, you'll learn about that hopefully soon. I'm hoping we're doing episiotomies less and less. Another indication, vagal stimulation. We don't want straining. We've had far too many patients that have strained and strained, and they're laying in bed and they're immobile and they're getting more and more constipated, and we're not addressing their elimination needs. Sidebar, anybody that I've had for clinical in my groups, that is one of those things that needs to be communicated shift to shift. When was their last bowel movement? We get ready to prepare somebody for discharge, and we find out they haven't had a bowel movement in 6 days. I mean, how would you feel if you hadn't had a bowel movement in 6 days? We're so occupied with all the information overload, especially as students in the acute setting, that we forget about these basics, the nursing 101s. And all the while, now they're straining and they're having vasovagal syncopal moments because we're stimulating that nerve too much. So we want to avoid that. We got to stay on top of this. Another indication, elderly, they have decreased muscle tone in their intestinal walls. Maybe procedural prep. We're going to talk about like the Go Lightlies for colonoscopies, and then of course decreased mobility. Now I understand within means and within limitations in the hospital, depending on what you've had, mobility is going to naturally decrease, but not so much as overstaffed, very busy units, not getting patients out of bed for 2 days, developing pressure ulcers. So I could go on that soapbox for a long time, and I'll choose not to, but I will stress that common thread throughout this whole lecture, how important it is to get our patients up and mobile so that we can maintain good natural elimination. All right, so the first stimulant we're going to talk about, a chemical stimulant, the prototype bisacodyl, brand name Dulcolax. So the indications for Dulcolax, constipation or colonic evacuation, pre-procedural examination. So our patients are going for a colonoscopy. Dulcolax will be used in conjunction with a Go Lightly, let's say. I think many of you guys have seen that combination and administered to your patients in the hospital setting or seen it administered. So what's the action of Dulcolax? It has a direct effect on the colonic smooth muscle by stimulating the intramural nerve plexus. So again, it's a chemical stimulant to the bowel, to the intestinal wall, and it gets things moving. It increases peristalsis. So ADRs is kind of interesting. And I always try every semester, I kind of, do a little deep dive, look into it more. Have we discovered any more ADRs on most of these meds? And there's not anything terribly significant that these directly cause to a patient. I'll talk about the indirect effects of these on patients. I think it kind of pops up in one of these just as a reminder, what this can do, what diarrhea can do. But the ADRs, as far as most of these meds go, are pretty insignificant. Nursing implications, however, if I'm giving Dulcolax to a patient, there's a lot that I'm thinking about. I'm thinking, are they mobile? Are they going to want to hop out of bed and go to the bathroom because they're feeling like they're going to be incontinent, they're a high risk to fall? So I'm going to set that bed alarm. I'm going to tell them, please call me before you get up. I'm going to tell them, I'm giving you a Dulcolax suppository right now. Please try not to worry too much. This is not going to work instantly like an enema or like a Go Lightly or something like that. If I'm giving a Dulcolax tab or even a Dulcolax suppository, it might be an hour or two before that works. So just let your patients know that. We need to be aware of the pattern of bowel activity. It kind of goes along with what I was just saying. Do not give with rectal bleeding. Okay. Encourage fluid intake. That always helps with improving the elimination. Ask the patient to report any unrelieved constipation. Let's just stay on it. Just don't give the Dulcolax suppository and then they go another 2, 3, 4 shifts without a bowel movement. Do not take PO route with antacids or milk. There is an interaction with that I'm not going to get into, but that's good to know. And then as far as the pararectal PR technique, that's something that we'll cover more in the clinical setting, but typically it's not absolutely necessary, but they do recommend having patient lay on left side, bring that right leg up, and I think I might even have a slide on the position. Let me see. Yeah, so here's the slide of how to administer Dulcolax suppository if you have not already done so. Okay, so the next stimulant that we're going to talk about is Senna. The brand name is Senocot. Senna is a natural laxative that does happen to have a chemical mechanism on the intestinal wall. It's actually derived from an herb. It's actually an herb itself. Not even like a derived herb, but senna itself is an herb that they've been using for a long, long time in human history. Indication, short-term relief of constipation, colonic evacuation of pre-procedural examinations. We don't typically see that in the hospital. If patients have a history of constipation or if they have not had a bowel movement, you'll typically see senna ordered twice a day for our patients, and it's just a natural laxative. That's what I talk to my patients about. Actions: direct effect on colonic smooth muscle by stimulating intramural nerve plexus. All right, and as we see again, not really any significant ADRs to talk about with senna. Nursing implications, common side effects. Sometimes we do see our patients that are taking it at least twice a day, 2 tabs twice a day, so a little on the higher side. Their urine might be a little reddish brown. We have to continue to monitor the bowel activity, encourage fluid intake, and some patients, because they know that it's a natural laxative, take this for weight loss, and that creates laxative dependence. So we need to be aware of that and talk to our patients about prevention of doing so. All right, let's get into talking about bulk stimulants. I'm going to talk about the prototype psyllium or Metamucil. You see it outside the hospital much more than we see it given in the hospital now. I feel like over the years, we gave so much Metamucil, and maybe 10, 15 years ago when Miralax came out, Metamucil kind of quietly went away, and Miralax has taken the place, at least in the hospital, for constipation, the need for relieving constipation for our patients. So indication for psyllium or Metamucil, treatment of occasional constipation. And it's also used by some patients or some people as a dietary fiber supplement. I don't see that so much anymore. This is definitely a generational thing. I would say folks that are 60s, 70s, 80s will tell you, especially when you're doing the admission on medication reconciliation, that they take a scoop of Metamucil and a tall glass of orange juice every morning. I've done it for years. It keeps me regular. Okay, so it's good to take note of that and to obviously indicate that in the medication reconciliation. But the action of psyllium. So psyllium is actually another natural way of relieving constipation, but it's from the psyllium husk. So the action dissolves and swells in water, providing increased bulk, moisture content in stool. So it essentially takes on that moisture, creates bulk, creates pressure, and indirectly increases peristalsis. All right. Oh, excuse me. Yawning now. So let's talk about the ADRs of Metamucil. It kind of goes with all of our other elimination meds, except for I'd be remiss if I didn't indicate esophageal obstruction. So with Metamucil, kind of going back to that, it's really a psyllium husk. And thinking about the mechanism, how it really absorbs water, it kind of absorbs water, bulks up, increases pressure, moves things through, right? We just talked about that. So unfortunately, if you can kind of put two and two together, and I know you all have your critical thinking caps on, if I'm not drinking enough water or fluid of some sort, where is it going to bulk up? And so back in the early 2000s, it was really kind of more around 2010, the FDA, they always have this acronym. It's called GRACE. So it's generally safe and generally recommended as safe and effective. That's GRACE with an S. And if they can't fully take a medication off the market for the rate of ADRs and how it's impacting patients, they will kind of classify something that falls into not GRACE, so not generally safe and effective. Not recommended as safe and effective. In granular form, so it was only in granular form that they really recommended. So they couldn't take the drug itself completely off the market. You'll still see Metamucil at the drugstores, but it might be in tablet form. It won't be like in ground up husk. But if you go to holistic markets or stores, you will still see psyllium husk available. And I'm hoping that people that are selling clients that type of, if they're selling them psyllium husk, that there's going to be a lot of education at that cash register, that they have to take a lot of fluids, okay, so that they can prevent the possibility for esophageal obstruction. So nursing implications, with all that being said, common side effects: abdominal discomfort, monitor for bowel obstruction, encourage fluid intake. Definitely highlight, bold. I should have had that in caps. Monitor bowel activity. Powders mixed with water, juice, at least 250 mils, and it can be taken daily, and it's provided over the counter. All right, so you wouldn't think this is bulk stimulant, but another bulk stimulant that we're going to talk about is the prototype milk of magnesia, magnesium hydroxide. Very common. If I have constipation, I'm going to go to the store and buy some milk of mag, right? You've heard that before. So indications: treatment of short-term constipation. Again, we don't want anybody taking these meds long-term. There's that laxative dependence that we're talking about. There's that psychological aspect of it. We don't want patients, essentially, it's not an addictive, it doesn't have addictive properties, but it's almost like psychologically addictive, if that makes sense. So the action of milk of mag, it's osmotic effect primarily in small intestine, and it draws water into the intestinal lumen. So the ADRs, pretty common, general. We don't want somebody taking milk of mag. I just have to go to the bathroom. Some people get bowel obsessed if they're constipated. That's kind of not surprising. It's understandable, but we don't want them taking shot after shot after shot of milk and magnesia, and now they're throwing up. They have intense stomach pain, so we have to talk to patients about the dosage, the recommended dosage. Nursing implications, talk to them again about common side effects. You're going to take this, but it is going to cause some cramping. That's a pretty expected side effect. Diarrhea, a lot of gas. It's contraindicated in renal failure. This is just another one of those, especially because it's got that magnesium aspect of it. We don't want, if we have patients, even the liver aspect, but if they're struggling with metabolizing a medication, but especially excreting it, we don't want milk and mag getting to toxic levels. Now we have that magnesium aspect in the bloodstream, so we have to be aware of the renal failure, renal function in our patients. We have to continue to monitor the bowel activity, encourage fluid intake, of course, and again, only use for short term. All right, the next bulk stimulant we're going to talk about is the prototype polyethylene glycol electrolyte solution, Go Lightly or Miralax. Miralax was just a combination, a clever little combo of two words, miracle laxative, so Miralax. A lot of our patients take Miralax on a daily basis until they kind of regain their baseline, moving around, eating well. Most of our patients are on Miralax at least once a day. And that's not bad. Again, I wouldn't stress too much laxative dependence with those patients unless they're going home to Miralax. And then I would say let's focus on a healthy diet, and let's focus on moving, ambulating as much as you possibly can so that you don't have to take Miralax every day, so that your body can naturally eliminate on its own. But I am grateful for Miralax. It's a great medication. Go Lightly is that on steroids a little bit. Well, not on, I shouldn't say that. That's just a play on words. But Go Lightly is just a very intense, larger, truly, literally in form medication. It comes in a big old jug. Maybe it comes in a little couple bottles if I'm doing a colonoscopy outpatient. But in the hospital, it's going to come as the jug. We have to fill it up. And it's quite a lot of fluid that our patients have to drink. I'm just trying to look. I know I had written down how much total they have to drink. 4 liters. 4 liters of Go Lightly. It's a lot of fluid. And please be mindful to indicate that in your INO as well. I'm so hard. It's like pet peeve number 1 for me with INOs, being compliant with our INOs, but especially when patients are taking Go Lightly. So it is nice, just as the generic name indicates, it is an electrolyte solution as well. So thankfully it replaces those electrolytes that might be lost with so many bowel movements. But the indication, bowel cleansing before GI examination or colon surgery, bowel prep. They will literally bring a patient down to do a colonoscopy or get ready to do a colon resection, see that a patient has not been prepped well enough, essentially clear and clean, and send them back up. And that just has so many implications. So we just have to be sure that our patients are very compliant to finish the course of a Go Lightly medication so that they will be ready to go the next morning for either a procedure or surgery. And what's the action? Osmotic effect. It's just pretty simple. Okay, so ADRs for Miralax or Go Lightly, again, it's not significant. The indirect ADRs are more so if we are having so much diarrhea with any of these medications. It eventually is going to have an impact on my heart and my kidneys, so that's something to be mindful of. But otherwise, direct ADR for Miralax is insignificant. Common implications, common side effects, I should say, fullness, bloating, some nausea. So oftentimes our patients that are receiving Go Lightly will have an order for Zofran or Compazine as well to help with the nausea. So that's almost, unfortunately, an expected side effect. We definitely need to monitor their bowel activity. If a patient we need to be aware of their mobility status. If a patient's receiving Go Lightly, I had a student that had a patient that was going for a colonoscopy and he was unable to get out of bed. When we did get him out of bed, for meals, he would have to be hoyered. So that was something that we had really kept at the forefront of our minds for this patient receive and go lightly. We had to turn and position him and change him at least every hour. So otherwise, when they're laying on their back, it's like a cork there, and they're not able to have any bowel movements. So we had to keep him moving so that we had to clear him out, so to speak. So being aware of the bowel activity, they immediately become a high risk to fall because they're, going to be using, even our most mobile patients, I oftentimes just get a commode right at the bedside. Somebody's getting a bowel prep, whether it's for a procedure or for surgery, get a commode at the bedside. So they're not, dragging their IV and tripping on, it becomes a safety hazard, okay? And it's just more convenient for the patients, and it better allows us to kind of check out that bowel activity. Are they clear yet? How do the BMs look? When I'm giving the shift-to-shift report, I'm able to tell the next nurse, hey, they're still not clear, and it's like 10 o'clock at night, and I know they're going at 8 a.m. for that colonoscopy. So we know heading into the night shift that nurse has got to really stay on top of making them take that go lightly, because before you know it, it's the end of the shift, and they didn't drink not one drip of the go lightly. So I think you can kind of get the breadth of how important it is to make sure they are compliant, make sure we're ensuring safety and mobility, being aware of those mobility needs. No oral meds within 1 hour of start of therapy. Why would you think that is? Because it's increasing motility. It's increasing motility for the whole GI tract, including the stomach. So you might have a lack of absorption of meds within 1 hour of starting go lightly, if that makes sense, and we don't want that. It does replace electrolytes lost, and there it is. So 4 liters, you want to ensure that they're drinking 240 every 10 minutes until consumed, or until they're clear, until the fecal contents are clear. Alrighty, so let's talk about Fleets. Fleets has been around forever. Fleets phosphosoda or Fleets enema. Here's another bulk stimulant, another medication for constipation. The prototype name is sodium phosphate, but you'll have a nurse say, I just got an order for Fleets for our patients, and I would say PO or an enema. And we just gave an enema last week to one of our patients. So it's still out there. It's old school, but they're still using it because it's very effective. So what's the action? It's a saline laxative that produces an osmotic effect in the small intestine by drawing water into the intestinal lumen. So it acts in ways that some of the others do as well. All right, ADRs, again, nothing terribly significant, but I did indicate as I could indicate this on every slide for ADRs for most of these. Always keep in mind, diarrhea that doesn't stop may result in dehydration, which can in turn cause serious side effects to kidney and heart. All right, that's something to just be mindful with all of these constipation meds. It's going to cause at times diarrhea. We don't want them to keep taking it if there's diarrhea present. Oftentimes, sometimes we're so task-oriented as students. We have all our meds together. I have Senna, it's a gentle laxative. I have metoprolol, it's a beta blocker, and I have atorvastatin, that's an anti-lipid. And I'll stop the student and I'll say, let's talk about the labs. What labs you're going to look into? What's the blood pressure and the pulse for that beta blocker? And I'll come back to that Senna because that's often overlooked. And I'll say, when was their last bowel movement? Oh, they've had like 3 bouts of diarrhea this shift. Are we going to give that Senna? I guess not. You know what I mean? So it's just one of those like general, very common medication, even Colace. When was their last bowel movement? They just had one, and it was actually very loose, and the nurse did. So I'm kind of just helping you guys put it all together. We have to look at the whole clinical picture, the whole comprehensive look at the patient, and do they need it, okay? Because we don't want the patients to continue to have diarrhea and then, yes, have cardiac issues, have renal issues, and some others. All right, so nursing implications on Fleets phosphosoda or a Fleets enema. Common side effects: abdominal cramping, nausea, vomiting, diarrhea, bloating, flatulence, laxative dependence. I always sound like a commercial when I'm giving some of these common side effects. Bowel activity, again, this is something where I'm at the bedside. Remember when I talked about the Dulcolax? If I'm doing Dulcolax tabs or a Dulcolax suppository, that takes time. That might take a couple hours to kick in. And now patient just rang and now they want to go to the bathroom and bravo, we had results. But Fleet's enema, if I'm talking about a Fleet's enema, phosphosoda might work within the hour. A Fleet's enema should work within 10 to 15 minutes, if not sooner, okay? So we administer the enema, and I'll tell and also too, because they're so cold, the Omnicell's cold, I'll get the Fleet's enema out and I'll put it in one of those like plastic pitcher liners, like really, really warm water, just to make the Fleets warmer. So I'm not squeezing in very cold Fleets into a patient. Any more than if I was doing a tap water enema, I'm not using cold water. I'm using warm water to put it in that tap water enema bag. Okay, so the same thing with the Fleet's enema. Drop it in one of those plastic pitcher, really, really warm water. Kind of bring that at least to room temperature, if not warmer, and then dry it off. Go ahead and go in and inject. It really does kind of feel you're just squeezing that Fleet's enema into a patient and letting them know we're going to be on standby. We're going to be right here for you because you'll probably need to go to the bathroom. Hopefully, cross our fingers, within the next few minutes, okay? 10 to 15 minutes. With patients taking Fleets, as any of the other constipation meds, encourage fluids. I just talked about the proper administration, and it's contraindicated in renal failure related to the phosphorus, especially if they're getting the phosphosoda, okay? So renal patients, they have typically have a high phos level, and we don't want to make them even more toxic with, super or hypertherapeutic phosphorus levels. Okay. All right, so we'll talk about, I think, the only lubricant that, and you would think that a Fleets is a lubricant, just even talking about an enema, but it's not considered as far as classification as a lubricant. So Colace, the prototype docusate sodium. Colace is technically a lubricant. Now we tell our patients it's a stool softener because it's not a full-on laxative. It is considered still in the class of laxatives, the therapeutic class, but the pharmacological class, I know this is like semantics and you don't care about the pharmacological jargon, but the pharmacological class is surfactants, all right? So it impacts the surfactant and essentially is a lubricant for giving this to patients. So indication, constipation, and we want them to reduce straining, all right? The action decreases surface film tension by mixing liquid with bowel contents. ADRs, yet again, not really applicable, not significant. I really should indicate. Nursing implications, common side effects, mild cramping, encourage fluid intake, bowel activity. I've been giving Colace to our patients for 30 years, never have heard. I mean, really scratching the surface or even doing a deep dive on any of this research with Colace, it's still very effective. I wish we didn't have to give it to patients as often as we do, because I truly believe a lot of this comes back to our lack of mobility with our patients. Excuse me. Which is, I will die on this mountain that when I was a young nurse, mobility was like top priority. And I just have never, it's just, to me, it's at an all-time low. I'm thankful for physical therapy. I don't like hearing from nurses, don't get them out of bed, because physical therapy hasn't gotten them out of bed yet. I've never seen or heard that at any other hospital. So that is discouraging for me a little bit. So again, here's my soapbox, mobility, mobility, mobility. But I am grateful for Colace because it is very effective. All right, and then the last thing I'll talk about is herbal. Our prototype is flaxseed. Again, we'd be remiss if we didn't include this because our patients, especially 60s and above, it was kind of like, back in the 60s and 70s were the natural, I'm not going to say hippie movement. I don't mind saying hippie because I love hippies, but it was just a very natural movement. Patients or people were eating better. They were tapping more into the holistic alternative medicine, things that have been used for thousands of years. Flaxseed was very, very popular to take for many reasons, but it's essentially a fibrous laxative and it helps to decrease cholesterol too. It does a lot of other things too. So a lot of our patients, the patient population 60 and above, which is the majority of our patients now, as far as numbers go, but we have to educate our patients when we're doing that admission. Do you take anything for constipation? How are your bowel movements? Oh, I do. I take flaxseed actually, or I take flaxseed for my cholesterol instead of taking atorvastatin or some of those other anti-lipids, which can have effects on your liver. I choose to take flaxseed. Well, if they're in there maybe I'm 65, 70 years old, and I have new onset AFib. I came in with AFib, and I'm taking flaxseed. It's going to affect my bleeding. It's going to increase my risk for bleeding. Okay, so we need to talk to them about that. Insulin. It's going to be a natural hypoglycemic too. So if I'm a new diabetic, that's something to consider as well. And hormone replacement therapy, it's going to increase almost like the cardiac effects of those. So, these are good to knows. Don't stress too much about knowing about flaxseed, but it is one of those things. I don't know if you'll see it on the NCLEX, but we always have to include with any of our pharmacological teaching the herbal aspects. But it really kind of kicking it back, I would say the herbal that we see most often in the hospital that is considered farm, but it's really herbal is senna. So that concludes my lecture on elimination. Hope you guys all have a great day.